In this morning's Health Watch, new prostate cancer screening guidelines. This is the second most common cancer in men, right after skin cancer. Big deal. Last year, there were about 192,000 new cases, but now the American Cancer Society says some screening measures simply are not worth the risk. Our Dr. Jennifer Ashton is here to tell us why. Good morning.
Good morning, Harry.
You and I have had this conversation many times before. Very confusing when you get the data. Let's talk about how the guidelines have changed first.
Well, let's go through it. What the basic guidelines continue to say, so this part has not changed, is that for the average risk person, the screening should start, the discussion should start at the age of 50. If you are high risk, if you're African American or have one or more relatives who've had prostate cancer, you should start the discussion with your doctor between 40 and 45 years of age. Bottom line, no routine testing across the board for every single man, regardless of their age.
No routine testing.
Right. Now, those are that has not changed. That's the basis for the foundation. To go to the new guidelines, what they say is that basically the rectal exam, the digital rectal exam, is optional. It's not the end-all and be-all test. It's not perfect. If you've had a low PSA blood test, you can extend your screening to longer time intervals, maybe every other year, maybe even longer, instead of every single year.
So if you have a low PSA number, you don't have to be going back year after year after year after year.
That's correct.
If it's low, there's a pretty good predictability that's going to stay low.
Yeah, and you can spread out those time intervals. And then lastly, doctors or healthcare providers should provide written material or literature to their patients to help increase what they know. Which
is so interesting, that last one, because part of that is doctors are so busy, they have to see so many patients. This is an actual conversation that needs to happen.
It is,
that
Harry.
doesn't.
And you know what? When people try to make medicine or the practice of medicine robotic or cookie cutter and remove the individual humanistic conversation between a doctor and the patient, that's where things fall through the cracks. So the more information the patient has, whether that comes directly from the doctor's mouth or in the form of literature, written or internet, the better.
This feels counterintuitive because so often we're always talking about early detection, more screening, early detection, more screening. My sense from these new guidelines is this is about less screening.
It is, because we know some things about prostate cancer, Harry. First of all, it is so common in men, as you said. As men age, the incidence of prostate cancer goes up tremendously. If you live long enough, most men, even on autopsy, if they die from something else, will have
find
exactly. Number two, all prostate cancer does not behave the same. There are some very aggressive types and there are some very slow and indolent types. So the thinking with the slower types is you don't need to go through all of the risks of biopsy and treatment, which, let's be clear, for aggressive treatment there is the risk of impotence and incontinence when you talk about surgery, that might not be worth it for all men. The flip side, however, is that there is a lot of prostate cancer that can be caught early, would be aggressive, and would go on to kill someone, that you would want to intervene and treat. It has to be individualized.
Isn't it interesting, though, just as a physician, because of this one disease, you get a high PSA count, all the guys I know, everybody's calling each other because every single doctor has a different idea about what the modality
That's right.
Be.
And here's what you need to know about the PSA. It's not just the absolute number that matters, it's the rate of change between that one and the last one you had. So it can still be in the normal range, but if it's had a sudden increase or bumped up dramatically, that might be an early sign that there's a cancer there.
And the other thing in this is that sometimes they're basically saying treatment is not necessarily the best idea.
That's correct.
Because it can be so slow moving.
For anything, whether it's a test or treatment, you have to go over risk versus benefit.
All right, Dr. Jennifer Ashton, thank you so much.